Good morning to all of you. It's my privilege to be amongst you all. Well, my topic is role of FFR in current practice. And this is a editorial by Dr. Colombo in latest version of JAC 2015 January. Diagnostic coronary angiography is getting old. Well, it says all. We have understood the limitations of coronary angiography, and as a clinician, I think we must answer two questions whenever we approach coronary artery disease. The number one question is whether the disease is being caused by which disease is causing patient symptoms, and two, whether it is likely to cause future cardiac events, and the best modality to answer this is FFR. Except for STEMI situation, whether it is single vessel disease, multi-vessel disease, left main coronary artery disease, serial lesions, bifurcation lesions, non-culprit vessel in myocardial infarction, and coronary bypass graft lesion. Almost every situation, FFR is of great help to us in day-to-day practice. Well, non-invasive tests give you an answer in single vessel disease, but I'll put forward some examples which will show you how it can be useful in certain situations. This is a 55-year-old male presented with unstable angina, and CAG showed single vessel disease. There was a tight diagonal 90% lesion and a moderate lesion in the LAD. And the FFR done across the diagonal was 0.78, FFR across LAD was 0.86. Emphasizing the fact that the angina is due to diagonal and he can be managed medically. I had shown this case about 2 years back in the same forum, same place, and the patient is doing clinically very well. Another case example, 43-year-old male, acute coronary syndrome, single vessel disease. This is the lesion. By visual analysis, lesion appears to be 40-50%. But if you do the FFR, it was 0.77, and he underwent PTC with stenting to RCA. Now, why all these things should happen? Why there is a visual mismatch? We must try to understand there are certain factors contributing to pressure loss across the stenosis. It is not only minimal lumen diameter, but the entrance angle, the eccentricity of the lesion, the length of the lesion, the exit angle, and the size of normal segment, which all contribute towards a ischemic or a non-ischemic FFR. A lesion like this would cause friction for the energy loss, may cause separation, and all this contribute towards the pressure loss. And this is a very important point to understand in single vessel disease. Well, the commonest situation in our day-to-day practice is multi-vessel disease. And tailoring revascularization will certainly reduce cost and probably would avoid need for surgical revascularization. And non-invasive studies, we all know, they have their own limitations, balanced ischemia, SPECT, everything we have gone through that this has its own limitations. And as the FAME study showed, functionally diseased coronary arteries are much less than the angiographic 3-vessel disease. Out of 100, only 43% would have 2-vessel or 34% 1-vessel disease. And this is an observation in our day-to-day practice, as would be exemplified in the next few cases. Case number 1, 57-year-old male diabetic, 2-vessel disease. And he was advised bypass surgery and referred to us. There were 4 lesions, diagonal, LAD, OM1 and OM3. We went on to do the FFR of all the 4 lesions. FFR of LAD was 0.85, FFR of diagonal was 0.81, FFR of OM1 was 0.90, and FFR of circumflex was, the third OM was 0.91. Stating that the most critical lesion was the diagonal lesion, and probably medical management is the perfect answer for this patient. So it can change your plan altogether, and all the lesions appeared so critical in this patient. This patient, 52 years old male, stable angina, diabetic, hypertensive, positive TMT and 2SL disease. He had total 4 lesions, one in LAD, one in diagonal. FFR across the diagonal was 0.91. FFR of the LAD was 0.92. There were another 2 lesions in the circumflex. This was obviously very critical. The FFR across this circumflex region was 0.76, and he underwent stenting to the obtuse marginal and the circumflex. The LAD and diagonal were left alone. Case 3, diabetic, hypertensive, recent non-STEMI, triple vessel disease. This was the ECG, and this you can see February 2013. The case was presented in India Live 2013. 2 years of follow-up. 3 lesions. Ostial moderate LAD lesion, about 80-90% obtuse marginal lesion, but the FFR is non-ischemic. Only RCA had a ischemic FFR, and he underwent PTCA to RCA, and 2 years of follow-up. Those lesions were deferred. Patient is doing clinically, medically very well. Coming to the third important category of left main coronary artery disease. Maybe we have about 5% cases in your practice when left main disease might be associated with distal coronary artery disease. Certain important points to remember: ostial left main disease, the FFR measurements have to be performed with the catheter disengaged and hyperemia induced by IV adenosine. Our routine protocol is to give intracoronary adenosine, but in certain situations like this, we give IV adenosine. Distal left main disease, we have to perform the procedure twice, one putting the pressure wire in LAD and another putting the pressure wire in the circumflex. When we talk of only isolated left main disease, we are obviously targeting the whole myocardium, and the FFR measured in any of the arteries would reflect the FFR of the left main. But when we have a distal left main, if the pressure wire is in the LAD, it would reflect the ischemia and LAD territory, and so is true of circumflex. Sometimes disease in the circumflex or LAD would modify the FFR of the LAD. And assuming that this LAD lesion is very critical and very proximal, this would certainly modify the FFR, and unless you treat this, you cannot get a true estimate of the FFR. And if it is indeed very critical and severe and proximal, it would underestimate the FFR of left main. And this has been elegantly shown by researchers in ship experiments. This is one example. There is a tight LAD lesion, and the pressure wire is kept in the circumflex. The FFR is 0.79. Moment you treat the LAD lesion, the FFR goes down and comes into the ischemic range. And this is very important to conceptualize, because whenever there is a lesion here, the left main is targeting only this vessel, and so the area of myocardium supplied by left main is less. Moment you treat this lesion, the area becomes more and the FFR becomes ischemic, and that is quite logical to understand. 3 situations in left main, ostial left main, not so difficult. When you have these 2 lesions, I have already highlighted. If you put the wire here, it will be possibly false positive FFR, and moment you treat this, it will come into ischemic range. And if you have a distal left main disease, a true bifurcation lesion, then it has to be treated in a totally different way. And this is a very celebrated slide shown across. But what I would like to show is that whenever you have equivocal LMCA, it is difficult clinically to send the patient back home. There is at least 29% or 37% mismatch in such lesions, and probably FFR gives a very good answer. And the best part is follow-up studies in those patients who have been deferred are doing very well medically. That is important message. Coming to 1 or 2 examples of left main coronary artery disease, this is a 57-year-old male patient, diabetic, hypertensive. He underwent PTCA to circumflex in 2012. And he presented again in September to us with stable angina. And we did the angiography, which showed moderate LAD disease, distal left main disease, and mild instant restenosis. We went on to do the FFR of the LAD, left main LAD, which was 0.72. FFR of the circumflex was 0.88. As we had suspected, there was a significant plaque in the distal left main, and we went ahead with stenting, 2 stents in the LAD and the left main. And this is a follow-up angio 5 months later. Patient is doing very well. Another example, hypertensive stable angina, distal left main disease with 2 vessel disease. And you look at the angiogram, there is a distal left main disease which is mild to moderate. There is a lesion in the diagonal. There is a lesion in the circumflex after this OM1. So obviously the left main and the LAD is a very important vessel. And we did FFR of that, which was 0.88. Now, if the FFR is 0.88, these lesions probably cannot influence the FFR of left main much, and therefore probably medical management would serve this patient best. So it can completely change your plan. So single vessel disease, multi-vessel disease, left main disease, now coming to myocardial infarction. This is another case of inferior wall MI, and the RCA was obviously the culprit vessel, but there was an eccentric plaque, 70% in the LAD, and FFR was 0.92. Patient is doing very well medically after doing angioplasty of the RCA. Coming to little complicated aspect of FFR, sequential stenosis. Sequential stenosis influence hyperemic flow and therefore pressure gradient across the other one. The distal lesion is more important, though it is difficult to predict at times, and it is a very complex relationship. And the best way is to do a pullback maneuver. And this just goes on to show how complicated it is when there are 2 lesions and how they influence each other, and there is FFR which is apparent and FFR which is predicted. But for simplicity, it is best to do a pullback maneuver. Now, this is a patient who is diabetic and who had 2 lesions, and I'll show you those 2 lesions, one critical lesion in the PLV and a moderate lesion in the circumflex. Pre-PTCA FFR 0.72, we put a stent here, and then check the FFR, it was 0.86, and we left the patient on medical management. This patient also has a follow-up of almost 2 years. Another patient, triple vessel disease diabetic, underwent triple vessel angioplasty, but I will highlight only the RCA angioplasty. There were, after the ostium, there was a diffuse disease of the RCA, and there was a critical lesion in the mid RCA. We put a stent here, and then wanted to recheck the FFR after the stenting. And when we put a stent here and recheck the FFR was 0.88. Ideally, post-stenting, you should have a FFR of 0.9 or more to give a good, favorable outcome in long term. This patient, being a diabetic patient, triple vessel disease, with a FFR of 0.88, just goes on to exemplify that patient probably has diffuse disease, and this is the best we could get. Now, it would be interesting to see how the patient would do in the long run. So I just want to show you that. Another case taken from Topol's textbook, very nice case. When there are 2 lesions very close by, they would influence each other. And the best thing in such situation would be first to treat this. And after treating this, the lesion, proximal lesion, which doesn't appear significant but shows gradient, needs to be stented. And I think this has to be done under a hyperemic pullback, and sequential stenosis can be treated nicely. In diffuse disease, again, we have to achieve steady state hyperemia. And you might have a situation like this, and probably in such situations, you can't do a angioplasty because there is no step up or step down in gradient. It is gradual decrease in the pressure gradient. So it is a diffuse disease. Well, to put certain points with bifurcation PCI, there are 4 situations when you can have FFR in bifurcation PCI. Pre-intervention, after main branch stent implantation, side branch angioplasty, side branch stenting. And the next few points have been given by Dr. Koo, who has done remarkable work in this field, and I have selected slides from his lecture. Practical tips. Do not gel the pressure wire. Adequate shaping of a pressure wire, important. Wiring from distal part of the side branch ostium. Body wire may be helpful. And keep in mind that it is extremely important to know the procedural safety and efficacy whenever you want to do FFR. In a short osteal side branch lesion, probably yes, it is justified. When in long multiple lesions, non-osteal, diffuse calcified, it is better not to do FFR and leave it, because the procedural risk may be much more. It may not be very easy to enter such vessels through a stent, particularly with a FFR wire. Pre-intervention FFR is useful in main branch and pure osteal side branch stenosis, Medina 001 with pullback tracing. Post-stenting, main branch and large jailed side branch, very useful. But not useful in small side branch or diffuse calcified or slow flow situations in stenting post-main branch. Post-side branch angioplasty, to assess procedural success and to predict the outcomes of after kissing balloon angioplasty, non-left main situation. And I am talking about non-left main situation in all these cases. And post-side branch stenting to evaluate residual ischemia. These are the situations in. Lastly, FFR and coronary bypass graft lesion, though there is not enough data, but still, it is a reasonable strategy to predict bypass graft patency and has superiority over the strategy of grafting all vessels with lesions with 50% or more stenosis. Patient you want to send for bypass surgery, do FFR of those moderate lesions and leave those lesions who have non-ischemic FFR. It is a good strategy. Always keep in mind that whenever there is a bypass graft, there are possibly three sources through which the distal bed is perfused: the native, the graft, and the collaterals. And in a situation like this, with an open native vessel, it is important to put the pressure sensor in the native artery distal to the anastomosis. If the native artery is closed, then probably you can place the pressure sensor in the graft. This is a point to understand, and probably now we have reasonable data, if not good data, in bypass graft as well. Well, where do we stand today as far as FFR is concerned? If FFR is the gold standard for functionally significant disease, this is where IVUS stands and this is where angiography stands. Far, far away from, and it is not difficult to understand that IVUS and angio both are anatomical issues. This is a functional issue, and there is a vast gap. SPECT, CT, then stress echo. Stress echo has more specificity, CT angio has more sensitivity, but then they are far, far away. And this truly gives us an idea about how FFR is so crucial in today's practice. Well, application of FFR requires adequate understanding of the physiology, skillful stepwise procedures, and precise interpretation of results. Very important. This is one of those rare situations in modern medicine in which a newer technology not only improves outcome but saves resources. Thank you very much.